Good afternoon, colleagues and the network. Just checking if the technology is working just fine. Are you able to get me clearly? Techno Spark 4, can I get a response from you? Patela.
Yes, we are able to get you.
All right, great, thank you. Okay, good afternoon, everyone. Good to have you back this afternoon. I'm Dr. Matibula Peter, joining you from the hub at UTH. In the hub, I'm joined by Dr. Kapolowe Kenneth. I'm also joined by our two coordinators, Esnat and Etambuyu, and our IT, Kote. I would like to welcome you this afternoon. We also welcome our expert for today, who's giving us a presentation on vaccination in COVID-19 in people living with HIV. The didactic presentation will be given by Professor Lloyd Mulenga. We are also joined by a panel of experts, Dr. Kalasa, Dr. Mwanza, and Ms. Ada Zulu. Okay, just a reminder, colleagues, on echo etiquette to keep our microphones mute unless you are asked to speak or give a response. And also, if we want to give a response, we can do it by show of raising a hand. Right, so at this point, I'll call upon our coordinator, Etambuyu, to just give us a quick recap on the session that we had last week. Then we'll proceed to the presentation for for today. So, Etta, over to you.
Thank you, Dr. Matibula. Good afternoon, everyone. So last week, we had a very interesting topic. It was talking about mother-to-child transmission, specifically HIV syphilis dual test and maternal syphilis management. Last week, we discussed that more than 95% of pediatric HIV infections come through mother-to-child transmission of HIV, and these cases account for 9% of new infections globally. Mother-to-child transmission of HIV is more likely among pregnant women who have syphilis, of which we all know that both HIV and syphilis can cause adverse birth outcomes to the newborn. Therefore, a woman with HIV and syphilis, according to research, it is estimated that a woman with HIV and syphilis is 2 times more likely to transmit HIV to her child than a woman who does not have syphilis. We therefore note that it is very cardinal to eliminate mother-to-child transmission to the HIV, to both. Therefore, it is important to note that we have to eliminate mother-to-child transmission of HIV and syphilis from the mother to child. Zambia has embarked on this journey of EMTCT of HIV and syphilis. And it has come up with an integrated approach, which is necessary to improve efficiency and quality of mother-to-child. So it has come up to this integrated approach is necessary to improve efficiency and quality of maternal child health services and ultimately reduce preventable adverse birth outcomes in these newborns. It was also recommended that early screening and initiation of ARTS in a woman if found HIV positive is important in order to protect these unborn children from contracting HIV. It was also recommended that the dual test should be used for all pregnant women and partners who have an unknown HIV status or those who are eligible for testing after 3 months and those who've never been tested for syphilis during the current pregnancy as they come for their antenatal visits. Thank you very much. That was our quick recap. Over to you, Dr. Matibula.
All right. Thank you very much, Etta, for that wonderful recap. I'm sure it was well digested by the network during the session last week. So without wasting much of time, I'll proceed to today's presentation, where we'll look at COVID-19 vaccination in people living with HIV, zeroing in on the updates on vaccination coverage in people living with HIV, and also to dispel the misconceptions and myths about COVID-19 vaccines. And lastly, to also discuss the approaches on how we can increase vaccine coverage in people living with HIV. So, like I said, for today's didactic presentation, we are joined by Professor Lloyd Mulenga, who is going to give us the presentation, and also we'll have some insight by our panel of experts. So at this point, I'll hand it over to Professor Lloyd to go straight into the didactic presentation. Professor Lloyd, are you able to share the presentation from your end? Great.
Thank you so much, Dr. Matibula. So grateful. Dr. Kapulo, also thank you for facilitating this session. Colleagues who have joined, first I need to thank you for the work that you continue doing for the people that we do care for. We, again, as I've said several times, we don't thank you enough And especially now, we do realize the challenges that you are going through. We have a lot of challenges with supplies, with drugs. These challenges are happening at a time when we have to fight against this terrible pandemic. Now, we need to emphasize the fact that despite that we are fighting COVID, we still have other problems that we need to deal with. And one of the major threats which we have is HIV. And this major threat of HIV compounded with COVID, if not handled well, can just get out of control. So we want this afternoon to just give an update on the vaccination coverage in people living with HIV. We also want to look at some of the questions that may arise and among individuals who want to be vaccinated, and also the approaches on how to increase coverage for people living with HIV. We right now have good understanding that individuals who are living with HIV have an increased mortality from COVID-19 if they get COVID. And also, if they have uncontrolled HIV, where the viral load is high, and high, most of the studies have referred to viral loads above 10,000, and also those whose CD4 is less than 200, the chance of them having severe disease does increase as well. And this calls for true adherence to therapy, for HIV therapy, so that if an individual with HIV gets COVID, then the outcomes would be better. Also, we have a chance because we are dealing with this group of people who are in contact with health services regularly, but also many individuals with HIV have non-communicable diseases. They have diabetes, they have hypertension, they have TB as well, though not a communicable disease. And all these diseases, they increase the chance of someone having severe disease. So it's important that we prioritize individuals living with HIV for vaccination. This circular memo was sent last year, again emphasizing the vaccination for people who are living with HIV in the ART clinics, the TB clinics. At any point where we interact with these clients, we need to offer the vaccines. And we are still emphasizing the fact that we need to adhere to this memo, and we need to broaden the coverage of vaccination to people living with HIV. There are a lot of questions which have been asked around COVID and HIV. We quite now understand that these vaccines and the ones which we are using are WHO authorized. They are safe for many, many individuals living with HIV. Some of the trials did include people living with HIV, and we have data from those trials which has been quite assuring. We are also confident that the ARVs which we are using, they do not give any major drug-to-drug interactions with the vaccines. However, we need to have a strict pharmacovigilance platform for following up of adverse events following immunizations as well. I'll refer to the main vaccines which we have and the information which we have from the SAM trials. Pfizer and Moderna vaccines. There is a report from Israel of 143 people living with HIV were on Pfizer. And these individuals had a viral load less than 50 copies per mil with a CD4.
I think some participants are not able to get you clearly. So we're just checking the internet now. At this point, we'll just pause for a poll question before you proceed with this, this slide. If you may allow me, Prof, to just poll a question and then we'll proceed. So there you have it. This is poll number 1 regarding the eligibility for COVID-19 vaccination among people living with HIV. The following are correct except 1. A, some of the trials of the vaccines included people living with HIV, and there were no increased safety concerns among people living with HIV. B, there are no drug-drug interactions between COVID-19 vaccines and current ARVs and other prophylactic medications. C, mild adverse events due to vaccines are more common or severe in people living with HIV. And then D, pharmacovigilance of adverse events following immunization must be instituted alongside COVID-19 vaccination. In a few minutes, we have about 341 connections. So far, 25% have responded to the poll. All right, so we have a good number of our connections that have responded to the poll. So at this point, we'll end the poll and share the results. The preceding slides after this poll actually speak to the poll question. So you can see, Prof, the response from that poll question. So I think at this point, I'll stop sharing the polls and allow you to proceed with the slides so that we speak to the poll question. At some other point, I'll interrupt you for another second poll. Yeah, just for you to keep in mind. Thank you. So we can proceed with the presentation. Thank you, Prof.
Thank you, Doctor. I'm sure I cannot see the results for the poll. Maybe you can speak to them before I proceed.
So with regards to eligibility for COVID-19 amongst people living with HIV, so this poll question was looking at which of these stems is incorrect. So there are 3 correct stems, and then there is 1 stem that is incorrect. So the majority went for C as the one that is incorrect. That is, mild adverse events due to vaccines are more common or severe in people living with HIV, which is that this was about 45% of the respondents, which is the correct response, actually. So this was good, actually. So we'll proceed with the slides. Thank you.
Thank you, Doctor. Indeed, as mentioned from that poll, we see from this study, which was in Israel, 143 people living with HIV, which showed that side effects were generally mild. But also notable from this was that those that had a high CD4 more than 500 had strong antibody response, which was equivalent to the negatives. However, those whose CD4 was lower, the antibody response was also lower. And we need to just take note of that and highlight the importance of people living with HIV to adhere to therapy so that the immunity can increase, and they have also better protection as well due to that. The other study which referred to is an Italian study. This one was looking at Moderna and was centered largely around adverse events. And again, 51% had one symptom and after dose 1, and 73% had one symptom after dose 2. No serious adverse events, but even as we know, the younger people tend to experience moderate to severe symptoms after each dose. And women and those with viral load more than 50 copies were also likely to have some more symptoms. Another study looking at just a small population, 100 people living with HIV on Moderna and Pfizer, found that 1 month after the second dose, the antibody responses were also dependent on the CD4 count. Again, this agreeing with the other study we looked at from Israel, where the antibody response was also dependent on the immune profile of an individual. We have also data around Oxford AstraZeneca with 54 people in South Africa, also 103, 54 were from UK. And all these were on ART with a pretty good CD4, where the antibody response were similar in the people living with HIV negatives, even comparable to those who had, were HIV positive. And even the side effects, there were no differences in the occurrence of these side effects due to the vaccines. Then we have another vaccine not yet approved by WHO, the Novavax. Now, this Novavax from the preliminary data has not given overall good vaccine efficacy. However, in terms of side effects, there is no difference in side effects between the HIV positives and also the HIV negative participants. Currently, we do not have any data besides these trials I've highlighted. No information on the effectiveness of other WHO-approved vaccines, the CoronaVac, the Covaxin, or the Sinopharm Verocells in people living with HIV. We have a study as well going on, a cohort looking at those that are vaccinated and the people living with HIV, huge sample size. And we should be able to get more data as we move on around the various vaccines, which include the Sinopharm, J&J, Pfizer, Moderna, and also largely the Oxford AstraZeneca as the 5th vaccine. So we now are confident of the data which we have. We also know that the booster, I think maybe you may go to a poll question, Doctor. Is it at this level when you want to give the poll question?
Yes, Prof. So our IT, can you just, we'll pause for a poll question. Just upload the poll question. All right, so this is a true or false question. So in individuals receiving high dose steroids or systemic biologics for conditions such as autoimmune conditions, long-term renal dialysis transplant recipients, that is solid organ or bone marrow, are eligible for a booster vaccine. So you indicate whether this statement is true or false, that individuals receiving high dose steroids or systemic biologics, for instance, those with autoimmune conditions, those undergoing long-term renal dialysis, and transplant recipients of both solid and bone marrow transplant, are they eligible for a booster vaccine dose? So this is a true or false. So responses are coming in so far. 91 of our 385 connections have responded, and so far 77% feel that this statement is actually true. Right, so I'll just give it a few more seconds before we can end the poll. At least we have the majority have responded. I'll just share the results. Right, so indeed, yeah, individuals receiving high-dose steroids or systemic biologics, such as those who may have conditions like autoimmune conditions or are undergoing long-term renal dialysis, or they are transplant recipients of solid or bone marrow transplants. These tend to be on immunosuppressive for a very long time, and they are indeed eligible for a booster vaccine dose, as we'll see from the subsequent slides that speak to this poll question. So you can see, Prof, from the response, the majority feel that yes, indeed, it's true that individuals receiving high-dose steroids and systemic biologics actually need a booster vaccine dose. At this point, I'll hand over back to Prof to continue with the presentation.
Thank you, Doctor. We did introduce the booster vaccines, and we gave guidance on which populations would be eligible for receiving that. And I need to highlight HIV infection among the conditions that we thought are needed to get the booster doses in the early phase, with also other ones which you've referred to in that poll question, those on high-dose steroids, those who are on immune modulators, those who are on long-term dialysis, and the transplant recipients. But also ourselves as healthcare workers, we are encouraged to get the kidney disease. Majority of individuals were correct to say we need to have the booster doses for this population, which is at high risk of getting the severe form of COVID disease. And this is the poll question which was referred to. Among the people that are living with HIV, if someone has just been diagnosed with or they have acute symptoms for HIV or even COVID or TB as well, those individuals, because of the symptoms which they may have, they would not be eligible to get the vaccines. If you start someone on HIV-related treatment, either for directly treating HIV, ART, or you give them cotrimoxazole or the prevention therapy, we also do not recommend giving the vaccines in these initial 2 weeks. And anyone who refuses to be vaccinated, you don't need to force them. However, you need to continue counseling them. And those individuals who are on PrEP or PEP, post-exposure prophylaxis, again, we want to wait for them to tolerate these drugs which they've just been commenced on. So those you may need to delay the time that you give the COVID vaccines. This is what was referred to. We have continued to emphasize the need for vaccinating the people living with HIV. Obviously, for the data that was presented, you see the safety is good, but also we know that the burden of disease, severe disease, is high among the people living with HIV, especially those who are not doing well. Western Province has done well in terms of percentages, with 23.9% covered. Lusaka with 32%, 52,000 already fully vaccinated out of the expected population of people living with HIV and on treatment of 175,000. Eastern 5.7%. Now, Northern is not doing so well. Northern Province, generally Northern and Muchinga are provinces where we have struggled with the vaccine generally. And it's sad to note that Northern can only give to 55. We did not have data from Northwestern and Copperbelt. But Luapula is disappointing that it could be at 6%, because overall Luapula has done well. It may be an issue of data, but Luapula has done well in terms of vaccination. Among the rural provinces, Wapula is high, and we need to just look at why are we lagging behind in vaccinating the people living with HIV in a province which has done relatively well with overall vaccinations. We have a number of workers oriented in how to give these vaccines. A number of facilities are providing these vaccines, and we continue providing the health promotion messages so that we can engage the community on vaccination and also targeting these high-risk populations. Some provinces are above 20% coverage, and we are grateful for this. We have had challenges as well. Space has been challenging, where we know in our limited HIV clinics or ART clinics, we have to find space for vaccination. The documentation has also been challenging, but also we have had some refusal rates which have been quite high in certain instances because of the myths, and we may not have provided enough IC to the recipients of care. At one time, there was a vaccine stock out, but again, this was just for a short period of time and was not countrywide. Then some differentiated service delivery recipients of care who are on those models, they opt out due to the long waiting time that is associated with the vaccination. And colleagues, what we need to do is to try and address all these challenges. Let's make it easier for the recipients of care to also get vaccinated. We need to prioritize them. Someone has come for the HIV services. Let's make sure that they don't spend more than 30 minutes extra for them to just get a vaccine. We need to also have the IC materials printed, and also we have various partners who can help with this. I know USAID, CDC are funding targeted towards the increasing the vaccine uptake. We also need to regularly monitor and provide technical support to various facilities, and we need to strengthen the documentation for COVID-19 vaccine uptake in our HIV facilities. Community engagement is key, and this is not just for the HIV, for people living with HIV. It's key for all the individuals that we are targeting. And right now, as we move on even to give vaccines to children, let's make sure that even those children who are living with HIV are not left behind. Let's get that information. It's something which is going to protect the overall community. Remember, we have a population of 11% Zambians living with HIV. In fact, even maybe slightly higher. If we vaccinated this, they would contribute to a high number of individuals contributing to that general protection for the community. Now, there have been a lot of myths and misconceptions about these vaccines. We have a number of bodies that look at the safety data, and countries also, they consider using the vaccine in persons older than 60 years. This should maintain active safety monitoring. But above all, we'll try and go through why is it that the major question is these vaccines were developed in less than a year. How can they trust them? There are 5 stages which they went through. Small groups of people received the trial vaccines. Then it was now increased to a larger population in the hundreds, looking at different diverse backgrounds, age, race, and also the health status of individuals. Then thereafter, it went in the phase 3 to being given to thousands of people who were tested for the effectiveness and also the safety. After that stage was done, then there are various advisory bodies on Scientific Advisory Committee on Immunizations. They had to give an input. Then the regulatory bodies, the FDA in the US, and also the European medical agencies as well, medicines agencies, looked at the data. And from that, after all these steps, then that's when countries did start using these vaccines. Of course, there's an exception. Like we know in Russia, they decided to start using these before there was even WHO authorization and FDA and EMA authorization. Similarly, in China, they also started using. Now, why was this process shorter? Now, the timeline was cut short, but the major ingredients in satisfying the safety and regulatory requirements were not eliminated. First, there was already much data known about coronaviruses, and also the US had invested a lot of money in vaccine support. Similarly, the European countries, the UK, German had also invested highly. Russia also and China were investing highly as well in these vaccines. And there are a lot of people participated in these trials, such that the recruitment period was also short. And the manufacturing was happening at the same time that the trials were also going on. So you can see the COVID vaccine timeline from research to initial development. After initial development, when the testing started happening among individuals and various participants being enrolled, at the same time, the manufacturing of those vaccines were happening. And the time the approvals were going on, the manufacturing had really reached high stages. After approval, it was just a time for delivery. So that cut short the whole process by possibly 2 years or so. And that's why we had the fast track in terms of the vaccines being available. Now, there are a lot of individuals who even call us, and I'm sure your colleagues have been called several times asking on COVID-19 vaccines, someone getting COVID-19 because of the vaccines. The answer is no. If someone is vaccinated and they test positive to COVID, it's not the vaccine which has given them the COVID. However, also people may think that if they are vaccinated, then they can never get COVID. No, they will get COVID. The transmission, of course, is lower among those who are vaccinated when they get COVID. For them to transmit to another individual, chance of transmission is lower. But also, the chance of them having severe disease is lower even when they get COVID. How about the side effects? Yes, we have side effects, which are there mostly tiredness, headache, pain at the injection site, chills, muscle aches, nausea, vomiting, fever, and these are usually self-limiting. Some may need to just get some analgesia, and these would really go. How about Johnson & Johnson? Where was it tested on? Some people think this was never tested at all. This, we had these involving more than 40,000 individuals from different countries, from the US, South Africa, Brazil, Colombia, Chile, Mexico as well. And you can see that there were Blacks, there were Asians, there were Hispanics. So different ethnicities were represented, and the gender as well represented, with female being 45% and the rest being male. So you see that there was quite representation. Similarly, when you look at Pfizer as well, it was the same thing, split in terms of gender between female and male, almost 50-50. But again, you have Black represented, the Hispanics, and also the whites, and the continents as well being represented. So you see that the studies were done in many, many areas, and we should be confident of the product. Now, we have people who may have severe allergic reactions. If someone has reacted to one vaccine severely, they may not get this, and this needs to be discussed with the healthcare provider. We have those that may be trying to get pregnant with questions of, no, I cannot get this vaccine because it may prevent me from becoming pregnant. The vaccine is safe. In fact, those that need to become pregnant, if they are vaccinated, the antibodies are able to cross over the placenta and also give extra benefit and protection to the baby. There is no evidence that there would be infertility arising because of getting the COVID vaccine. How about those who are pregnant and those who are even breastfeeding? We now have data that if someone has COVID, the chance of them having adverse pregnancy outcomes is high. Preterm birth occurrence is high. Also severe illness for the individual is also high. And this is the population which is also targeted highly for vaccination. So pregnant and breastfeeding women, they need to be provided with vaccines. I'm sure you saw that with the Omicron variant, we admitted almost a rise of more than 50% among the female, just like among the pregnant women. There was a time the hospitals were fighting on where should the women go because there are just too many pregnant women. I know this story in Lusaka. Levy was saying, no, we have so many pregnant women admitted here, we have no space. UTH also was complaining, we have no space for these pregnant women. Again, it's because Omicron affected a large population, including pregnant women, just like children as well. And we realized that there will be more adverse outcomes for COVID-19 for the pregnant population. And we do emphasize vaccinating those who are pregnant, even those that are breastfeeding. Are these vaccines safe for children? Absolutely. These vaccines are safe for children. Now, those which are safe for children, we have now, and very soon Pfizer will be given to those who are even below 5 years. Right now, it can be given from 5 years and above, but what we have in country is only for those from 12 years and above. The rest, the AstraZeneca, Sinopharm, Johnson & Johnson, the Moderna, can be given Moderna from 16, the others from 18 years and above. And the safety profile has been relatively good. In fact, more safety parameters towards children as opposed to the adults. Some people think that if they get the COVID-19 vaccine, it will also change their genetic makeup. Of course, this is not true. What the vaccines do is just to teach the immune system on how to fight once those antibodies are generated. Even when you look at the mRNA vaccines, the Moderna and also the Pfizer, they do not in any way go and change the DNA of an individual. What they do is they generate the genetic, the proteins, which is based on the information from the RNA of the vaccine itself. And questions on do these vaccines work against the COVID-19 variants? We know very well that the viruses do change. So far, we have had a lot of variants. The Omicron variant is the one where vaccine efficacy was reduced highly, and that's why there was need for a booster. This is because of the major changes which have happened. And this mutation is not just for COVID-19. There's a report which I think some of you will see it soon on HIV diversity as well, undergoing variants as well. There's one which is reported in the Netherlands and certain countries in Europe, which is more deadly than what we have, the subtype B, the subtype C as well. This is a subtype B variant. So these changes are expected for many viruses. And sometimes when they are such, you can have an escape phenomenon where the vaccines may not be working. And so far, we know that there was a reduced efficacy with the Omicron, and booster dosing was important. How long after getting the COVID vaccine does it take to be effective? Usually it's about 2 weeks. The body is able to get enough antibodies to protect. We do not know how long the protection will last, but so far we have some evidence it may last more than a year. And for certain individuals, it may go, it may last, the protection may not last very long, 6 months or so. And that's the reason there's a need to have the booster doses. But anyway, over time, we'll be able to know how much long this protection does last for different vaccines. If someone is vaccinated, we still emphasize that it's a good idea to wear the mask in certain situations. I know Europe, certain countries in Europe have dropped that, largely the UK, Denmark as well. But you know, our scenario is different. Those individuals in those countries have high vaccination rates. We have very low vaccination rates. We're in the low 20s. So we cannot afford to relax and say we don't need to wear masks. For us, we are still a country with a population which is at higher risk of getting COVID and getting even the severe forms of COVID. So putting on mask is still highly encouraged. So in summary of the key messages that we need to emphasize is people who are living in the community, you need to interact that. We need to make people understand the need for them to be vaccinated for overall protection of the community. But we also need to address the barriers which may be there for one to get the COVID-19 vaccines. And we also need to make it easier for our clients or our various people that we are serving to get these vaccines. There are a few approaches on how we can increase this coverage. We need to look at preparation for the vaccine's arrival, ensure that there is enough communication. Let's maximize on the use of traceability systems, such as the barcode or the QR codes. We need to ensure that you have enough transport, we have enough storage, and also the timing that it arrives, the timing is very key so that we can maximize on the COVID-19 vaccination without wastage. We reported last week, we had more than 70,000 vaccines which were at risk of expiring. That is Pfizer. By the end of the week, by Friday, at least we had reduced to less than 40,000. And we hope that we are not going to expire any of these. For Pfizer, it's very important as once it's come out from the ultra deep cold chain, we need it to be utilized within a month. And that's why the timing is very, very important. This, how they have for the team lead, on the vaccination site, you need to have the vaccine doses which have been received, which are the targets which you have, and also the related supplies of the vaccines, you need to have them ready. We need to have a safe site for COVID vaccination, where you can screen for eligibility, screen for symptoms as well, and an area where there should be enough space for physical distancing. And once registration is done and the vaccine is given, observe for a few minutes before someone leaves the area. This area for vaccination should be a well-ventilated area, and a one-way client flow is advised. About the ART sites vaccination setup, again, we need to identify spaces within our ART facilities, and we need to identify staff who are dedicated to deploy in these key strategic places. And we need to have a focal point person responsible for vaccination of their people living with HIV in our various facilities. We need to leverage on the ART services for the COVID-19 vaccination. We know that our ART services, at least they have a reasonable amount of human resource. There is some space, there is some at least systems able to give these vaccines. It's not very complicated, and we need to utilize all these available. For any vaccine delivery strategy, the community, we need to have them engaged. And we need to, again, have the safe vaccination sites with adequate quantities of the vaccines and also the related supplies. Storage is very key. And the recommended arrangements of the vaccine is in the isolate areas. And I'm sure this is now capacity has been built in various facilities for us to have good storage of these vaccines. We give again these examples of poor vaccine storage practices, or those are just bungled up. You cannot even account for them. And this is something which we need to really avoid. We need to have vaccines where you can account for them well aligned and in a box with the packs available so that you can maintain the cold chain for these vaccines. Again, as a precondition, the ice packs, they need to be available as you are transporting these vaccines and preferably they should be in a single row, but in never more than 2 rows as well. This is what we're saying, make sure that the refrigerators are defrosted as well before you have the vaccines being sitting. The IPC is also very important. We don't need to crowd our places where the individuals are coming. We need also to continue screening for any symptoms of COVID among those that are getting vaccinated. We continue providing health education, and also all health workers, we need to sanitize, we need to have medical masks, and also observe the various infection prevention and control procedures. Now, these ones will also apply for any respiratory illnesses as well, where you have the various controls. You have a quick assessment of the facility, where if you have an IPC plan and a focal point person, you look at the environmental controls, largely it's ventilation, and also do we have enough personal protective equipment, and are we putting on that equipment appropriately? So the importance of making ourselves safe, it cannot be really overemphasized. We need to protect ourselves. We need to mask up. We need to wash our hands frequently, but also we need to physical distance so that we can protect not only ourselves, but also we protect the community. Hand hygiene, very important, but also the respiratory hygiene and coffee etiquette are very important as well. And as we have said, PPE wear with safe injection practices and safe disposal of the waste, these are very key for us to have a clean environment. With that, Doctor.
All right. Thank you very much, Prof, for that elaborate presentation on COVID-19 vaccination with regard to people living with HIV. Indeed, colleagues, we've seen that people living with HIV are eligible for the COVID-19 vaccine. And in terms of our coverage, we've seen that Lusaka, in terms of coverage, COVID-19 vaccination, Lusaka was at the highest with 32%, with the least being Northern Province at only 1%. And indeed, we need to leverage on our existing ART services in order to improve on this coverage. And we've dismantled some of the myths that are there when it comes to COVID-19 vaccination in people living with HIV. So before we can look at the questions, some of the questions in the chat, I would like to invite our panelists to just give a few comments before we can go to the questions in the chat. If Ms. Ada Zulu is still on the call, Dr. Mwanza and Dr. Kalasa, in that order, just under 2 minutes. If we can just give some comments with regard to COVID-19 vaccination in people living with HIV. Over to you, Ms. Ada Zulu, and then Dr. Mwanza, and then Dr. Kalasa. Over to you, Ms. Ada Zulu, if you're still on the call. Please give some comments. COVID-19 in people living with HIV, with your experience in the field. Right, if Ms. Ada Zulu is not on the call, Dr. Mwanza, you can go ahead, just under 2 minutes. Give some comments before we go to the questions in the chat. Over to you, Dr. Mwanza.
Okay, thanks. for the opportunity, and thanks, Professor, for really a very well elaborated presentation that has really covered actually what is happening on the ground. And of course, there are few strategies that Lusaka Provincial Health Office has been implementing in terms of improving the uptake among people living with HIV. Of course, one area that we are not doing fine has been on demand creation when it comes to COVID-19. So it is one area that we are still working on in terms of translating some of this information in the local languages so that people can really have access to information. Then the other thing which I need to highlight on demand creation has been also the use of social media that we really need to scale up, because if you have seen some of the information that is coming using the social media are just anti-vaccine. So as a program, we really need to work hard in terms of improving community sensitization as well as demand creation using the media platform. Then I can also just highlight one important thing that is based on some of the frequent asked questions and as well as some of the additional information on COVID vaccine. And we know that COVID is really very dynamic in terms of demand for information. And there are a lot of changes that are happening based on the adaptation that the Ministry of Health is taking in terms of, for example, the age for vaccination. So I can also report that through the health promotion, work is still, last week, they were working on actually adapting or adjusting some of the existing IC materials in terms of the age and some of the questions regarding the children. So in the nutshell, that's what I can say or add to what Prof has indicated. Of course, we are still having a high rate of refusal rate within the facilities within Lusaka, as well as I can say that the uptake also among healthcare workers has been quite high. We managed to vaccinate up to 54 quotas of healthcare workers, and we are still having a quota of healthcare workers who need to be vaccinated. And these play actually a key role in terms of demand creation as well as one-to-one counseling with the patient. Thanks. That's what I can add from my side.
Okay, great. Thank you for that reflection, Dr. Mwanza. Greatly appreciated. I'll now ask Dr. Kalasa, if you are still on the call, just your comments on COVID-19 vaccination in people living with HIV. Over to you, Dr. Kalasa. Okay, Dr. Kalasa seems to have dropped off. Right, so now I'll open the discussion to the network. Any questions, concerns from the network? If you could please raise your hand on the hand icon. If there are any questions from the network, if you can please raise your hand. Okay, the chance of raising the hands is going once, going twice. Okay, great. I can see a hand up. This there is one hand up. Luanja Aika, if you could unmute and go ahead with your question or contribution.
Thank you so much, Doc, for this opportunity. The question that I have, I've typed part of it, but the question I have is on those that have never been vaccinated before, but probably have recovered from COVID. For how long are we supposed to wait before we can vaccinate them? Or do we still need to vaccinate them even after they've already suffered? What is it that the vaccine is going to do that the natural immunity hasn't already done? I think that's my question. I would love a comment on that. Thank you.
All right, thank you, Wanja, for that question, comment. I'll allow Prof to respond to that question. Okay, I'll allow Dr. Wamwanza to respond to that question. Those who've had COVID-19 and versus giving them vaccination, what's your comment on that one?
Yes, I hope I'm audible enough. So from, yes, the guidelines, once someone has suffered from COVID, the first thing we need to consider first is to wait until the symptoms are subside. And once the symptoms are subsided, usually it's within 10 days, then they can be given the COVID vaccine. Then, of course, there is a level of immunity that one gets after getting COVID, but that immunity usually it won't fast. So that's the reason why we should vaccinate people even if they have suffered from COVID-19. And there is a literature that supports that we could share with the participants. Thanks, over to you.
Thank you very much for that response, Dr. Wamwanza. Yes, indeed, yeah, we even have our post-acute COVID-19 clinic where we really encourage people to be vaccinated even after they've suffered from COVID. But of course, after the symptoms have subsided, after the acute phase is over, then they can be offered the vaccination. There is a hand from Prof. Prof, you can unmute and go ahead with your comment.
Sorry, I was failing to unmute before. I think just agreeing to what Dr. Wamwanza has indicated and also Dr. Matibola. There is no contraindication to vaccinating someone who has recovered from COVID. In fact, you can even vaccinate someone even when they have COVID. I know this has arisen several times where saying some people expect first they go for a COVID test. Once the COVID test is negative, then that's when they go and be vaccinated, as though the two of them are linked. There is no contraindication to getting the jab. So people, as long as they don't have symptoms, the reason is we don't want the symptoms from the vaccine to be confused with the symptoms from the COVID, because the COVID-related symptoms may have different implications in terms of management. However, if someone had COVID and they have recovered, the immunity which they may have may not last long, and that's why they need to get the jab. But once they get the vaccine as well, there's some data which has shown that those that have recovered and they also get the vaccine, the protection is also higher. The antibody response is higher, the T cell response is also higher, such that the protection is enhanced even in those that are vaccinated and they had COVID before. Thank you so much.
Thank you very much, Prof. Yeah, indeed, some of the questions actually in the chat have actually been addressed as we were going through the presentation. There is another question, if you allow me to go to the chat, from Jonas Hines. Is why do we wait to vaccinate people living with HIV for 2 weeks when initiating ART? Is it that we don't want to confuse the symptoms, we don't want to confuse iris with adverse events following immunization?
Jonas, yes, you are spot on, but in addition to the iris, but also just the side effects which are related to the ART. So we want someone first to settle on, in fact, on all those medicines, if it's TB medicines as well, if it's the HIV medicines, the cotrimoxazole as well. So we want someone first to make sure that they do not have any side effects related to those. But also iris is also a possibility to various conditions. And that's the reason we want someone to settle in so that we don't have a confusion between the two. Thank you.
Thank you very much, Prof. Right, okay, so another question from the chat. I think this partly has been attended to from Kansaka Rural Health Center. Does an individual who has never been vaccinated but has had history of being diagnosed with COVID develop antibodies against COVID-19? I think Prof had alluded to this earlier. Yes, they develop antibodies, but there is evidence to show that when you get vaccinated, there is additional protection, and the antibodies due to infection may not last very, very long. I don't know if there are any more additions, Dr. Mwanza on this question.
I've seen the Prof has got his hand raised. Maybe can go ahead. I don't have any addition to this.
Okay, thank you. Prof, you can unmute and go ahead with the comment.
I'm sorry, I have no comment. I think it was the previous hand I raised.
All right, okay, thank you. Thank you for that. I think that question was well addressed during your response to the previous question, actually. Any other hands that are there? There's another question from the chat. Can someone who has had 2 infections of COVID-19 be vaccinated with Pfizer? Okay, yes, just a quick response to that. Prof, someone who's had 2 infections with COVID-19, can they be vaccinated with Pfizer or indeed any other vaccine?
Yes, they can be vaccinated. And I think Jonas in the chat lists that, not just for Pfizer, but for any vaccine. I think that natural infection, the immunity from natural infection, compounded with the immunity which someone gets from the vaccine, it gives better protection. If Jonas is connected, maybe he can give a comment over that.
Okay. Dr. Hines, if you're still on the call, you can give a comment on that?
The question was about the immune response after natural infection and vaccination, and whether or not Pfizer was recommended. I think that there's not, yes, the recommendation is for people to become vaccinated after even if they've had an infection. The reason is because immunity wanes. We know that from our experience with COVID now, but that's also the pattern that we see with other coronaviruses. And the immune response that you get after vaccination is different than the immune response you get from natural infection, and they build off of each other. So the people with the strongest immune responses when they test them in the labs are the people who had an infection followed by vaccination. So absolutely, if someone's had COVID, they should still be vaccinated.
All right, great. That was spot on. So even if people have had COVID-19, 2 infections, they can still be vaccinated. I hope that's very clear. Right, so there is another question now dealing with pregnant women. In pregnant women, or at least women who have been vaccinated before, are the antibodies passed on to their children? So maybe before Prof can come in, if you have any comments on this one, Dr. Wamwanza can go ahead and give your comments. Are the antibodies passed on to the child when the mother is vaccinated? Right, yeah, I think Prof spoke to this during the presentation. Probably if you can amplify that more, Professor Mlenga, antibodies being passed to the child, you can unmute and just amplify that point.
We know, yes, that the antibodies do cross over the placenta and give the protection. And there were fears before that do the vaccines also cross over? No, the vaccines don't want to cross over. It's the antibodies generated, the maternal antibodies, which you cross over to the placenta and give form of protection to the babies. Again, something positive and encouraging those that are pregnant, even those that are breastfeeding, to get vaccinated. Thanks, Doc.
Thank you, Prof, for that. Are there any other questions, comments from the network? You can show by raising your hand and proceed with a question or comment before I revert back to the chat. Okay. All right, great. So there is a hand from Patrick Makelele and Matthews. So in that order, Patrick, you can go ahead with your question or comment, and then Matthews, and then after that we can give responses to the question. So Patrick, you can unmute yourself and go ahead.
Okay, for me, it's not a question, I think it's a comment. Or it can be.
Okay, Patrick, you are muted.
Okay, my concern is I'm raising a concern on safety and ethical consideration, especially for the vaccine which has been extended to the younger one in the schools. When we are monitoring on the ground, sometimes parents have got mixed feelings in terms of how we are handling things. Like what evidence do we have that the parents have given a consent? Do they write just a yes on a piece of paper, or you can vaccinate my child? Is it possible at national level we come up with a standard form of consent? We may just raise a model that when the parents have accepted this one sentence or two and sign, they give in LRC, then it's considered. I'm considering this in a way of protecting ourselves. Are we doing the things right, or are we doing it in the right way? I submit.
Can I go ahead?
Prof, you can go ahead.
Dr. Makelele, yes, thank you. And we are very careful with consent for children. And there is a form which has been generated nationwide. And this was from the Ministry of Education. The Ministry of Health did input. So there is a standard form. It's not that it's just any piece of paper where someone writes. However, there are also modifications. There are certain parents who may not be where the children are, especially those who are in boarding. And there is information which is conveyed to the teachers, and that is what we are using. So yes, we are respecting the ethical values. We do not vaccinate a child who cannot give consent without the guardian or the parent giving consent. Thank you.
Thank you very much for that, Prof. Yeah, actually, I'm being informed that certain schools are even giving consent forms to the children to take to their parents, so that the parents can sign. Yeah. So we have another hand, Dr. Thierry Malewe. You can unmute and go ahead with the question.
Just to.
Yeah. Hello. Just to add from what the Prof has said, actually for Eastern Province, we even have some version from that initial English version in Tumbuka and other local language, just to make it much easier for the parents to sign and give that consent. So we are really following that, and making sure that when we embark following these children in school, that consent should be obtained. Thank you, over.
Right, thank you for that submission.
Just to add also, this is Mwanza. I hope you can hear me.
We can get you loud and clear, Dr. Mwanza. You can go ahead.
Yes. Then in addition to what has been said, apart from the forms, then you recall that when we started vaccinating children, they were still on holidays. So, and some schools, actually most of the schools, they are requesting either for the vaccination card or a copy of the vaccination card, especially for those children who need to get their second dose while they are in school. Thanks, over to you.
All right, great. Thank you very much for those comments. There are still more hands. Ida Zulu, you can unmute and go ahead with a comment. Then we'll have the comments from Matthews JSI after that, in that order.
Thank you very much, Chair. You just as the Prof have said, on the grounds where we are, as we are going around to do the vaccination, at times we may even find that some areas even parents are following, and there is a standard consent form which is actually attached to the form that is being used as we're doing the vaccination. So no vaccination is actually parents, unless when we have a parent who said I'm here, and actually they're actually consenting on their own, they're even doing the signing on their own. So there's a generic consent which is being done for everyone. I submit.
Thank you very much, colleagues. We've heard that consent forms are there. Okay, Matthews JSI, you can go ahead with your comment or question. You can unmute.
Yes, thank you so much, Dr. Kozia. Matthews from GSI Central Province. Yeah, I want to just to share a strategy we are using just to boost the number of vaccinations for our ART clients. So in Central Province, yeah, we've embarked on a community approach where we are following our clients on art from their workplaces, and particularly in farm blocks, knowing the fact that much of Central Province is actually an agrarian region. So we are following our ART clients and then organize with the farm owners and then have them vaccinated from their workplaces. The result has been good. Quite a good number of our clients have been making that approach. Now, we still have a challenge because we have some farm owners who deny their clients to be vaccinated. So I just wanted to find out from the people on the call on the best course of action for such scenarios where the farm owner, for example, refuses for the clients to be vaccinated. What's the best course of action? I submit. Thank you.
All right, thank you for that comment. Any reactions to how we can tackle that situation? Colleagues on the call where the farm owners are refusing their workers to receive the vaccine. Probably we can hear from our panelists.
Yes, I can try to address that. Thanks for bringing that issue, and that clearly shows some of the myth and misconception that we have in the community. So, and one of the most successful strategy to address that, it is sensitization with involvement of those community leaders or responsible for those farms, so that we can actually address some of the myth and misconception they have about the vaccine. And this is one of the strategies that will promote interaction with the providers, the healthcare providers, and it can actually help them understand the importance of the COVID vaccine. Then, of course, we need also to engage the client themselves, and this is very important, especially if they are able to consent, and if we have provided enough information in terms of sensitization and demand creation activities, they can consent and they can get the vaccine. But the key strategy is just to engage all those farm owners on the importance of one get COVID vaccination. Thanks. I don't know if Prof can add to what I've said or anyone. Thanks.
Thank you for that, Dr. Mwanza. I think Prof has just gone off the call. Probably I'll allow Ida Zulu to give a comment. So Ida Zulu, you can unmute and give your comment.
Thank you very much, Chair. One strategy we've used, like in Lusaka, is using the farm owner, like in Plhiv area, in these other areas, where the one who has caught you on, maybe you've gone to 2 farms. Those owners
Ground. Ada Zulu, you have muted yourself. We cannot get you. Please unmute and go ahead with the comment. In the interest of time, this will probably be the last comment. You can unmute Miss Ida Zulu and give your comment.
Sorry for that. I was saying one strategy we've used is making the farm owners who have allowed their workers to be vaccinated to become champions in that area. And as staff have meetings, because usually those people have meetings, as they're even doing their sales, they sensitize other colleagues. And it has helped that most of the farms has been reached, like in State Lloyd area, and even in Chongwe area, we could even tell Chongwe teams to say, these people need to be vaccinated. So it helps. Other than just us going with health promotion, we make even those others to become part and parcel of sensitizing the issues on vaccination. I submit.
Thank you very much, Ms. Zulu, for that comment. Colleagues, in the interest of time, would like to thank our panelists for today. Thank you for coming on board and giving your comments and your experts. And thank you to Prof for that wonderful didactic presentation. Colleagues, we've seen that people living with HIV are actually eligible for vaccination, so we shouldn't deny these recipients of care. And with regard to updates, using some of the strategies that have been highlighted, we should use them at least to improve some of the coverage of COVID-19 vaccination in people living in HIV, and especially in provinces that have very, very low uptake, like the northern province. We can actually leverage on our pre-existing ART services to offer COVID-19 vaccines to people living with HIV. With that, colleagues, we'll call it a day. Next week, Monday, we meet again, same time, 14:30, and the topic for next week will be bi-directional screening of COVID-19 and TB. Thank you very much to the network for the attendance. Please continue, and thank you to Prof and our panelists for taking part in today's echo session. From the hub at UTH, goodbye and good afternoon. Thank you.
Bye. Thank you.